So we're back. Cecilia and I are going to toggle back and forth, and this is Carrie Morgan, and I'm happy to be able to introduce our next speakers. And sorry, let me just minimize my screen. Thank you. So our next session is on complete and incomplete AVSD. And this is being presented by Letenwe Morudo, Tashira Mosito, and Sina Nadolovu.
Can I go?
Yes, please. Thank you.
Good afternoon, everyone. Like Carrie have said, my name is Litino Morudu. I am with Tshireletso Mosito and Sina Ndlovu. We are presenting atrioventricular septal defects. And then we, like she has already said, we've got partial and complete. We started by defining what is atrioventricular septal defect. And then it is a congenital heart defect in which the walls separating all four chambers of the heart are poorly formed or are absent. And then that includes the malformation of the valves that separate the upper and the lower chambers of the heart, which are the mitral valve and the tricuspid valve. And that is why we said it can either be complete or incomplete. And then it is also known as endocardial cushion defect, and then it can present at birth. Both present at birth, pre-birth and post-birth, postnatal. And then how is the atrioventricular septal defect formed? It occurs during the embryonic stage, that is during the first 8 weeks of post-conception. It developed as a result of the interaction between the intraventricular partitioning, the endocardial cushion, and bulbar ridges that separate the great blood vessels of the heart and the formation of the mitral and the tricuspid valves. Here you are looking at a picture of how the heart develops from the 18th day post-conception up until 35 days. And the bottom pictures are showing you the sagittal picture of the heart between 28 days and 8 weeks. And then on this slide, we are showing you, we're saying that there is failure of partitioning of the two sides of the heart. And here you are seeing the normal heart that shows you the normal development of the septum, the normal development of the right ventricle, the left ventricle, the right atrium, and the valves that are involved. While on your left, your right, you're seeing the atrioventricular canal, which we said is the endocardial cushion defect. And you can see that the blood is actually shunting between the left and the right for both the atria and the ventricles. We have already said there are two types, which is partial or incomplete atrioventricular septal defect, and there is also a complete one. Now we can talk about the partial. They say it occurs on the part of the atrial septum near the atrioventricular valve. There is no intraventricular communication. The anterior and the posterior bridging valves are fused by a connecting tongue that separate the right and the left ventricle orifices, and the cleft is also on the mitral and the tricuspid valve. And this is a picture that shows you the two types, even though sometimes we say you might find there's an intermediate or a transitional one, but we are mainly focusing on the partial and the complete one. Okay. And then the common types of the partial or the incomplete, we say there is less common ones, which is the common atrium, a characteristic lesion that is seen in the Ellis van Greveld syndrome, and the VSD on the septal inlet, which is the AV canal, also isolated cleft of the mitral valve. Then they say the prevalence is 1 to 2 of patients with, it's seen in 1 to 2 patients with chronic heart diseases, but is much lower than the secundum atrial septal defect. Now we're talking about the complete AVSD. The complete AVSD is also known as AV canal, and it consists of the following: an ostium primum ASD, an inlet VSD, and the clefts in the anterior mitral valve leaflet and in the septal leaflet of the tricuspid valve, forming the anterior and the posterior tricuspid valve cusps of the atrioventricular valve. Hence, in the picture that we showed earlier, they talked about a tongue. We can go slightly backwards just to show you. They say it's a tongue of tissue that divides. And then it also shows you that the shunting of the blood. This is what we are trying to explain. And then, and here, we are actually looking into a much more clearer picture that shows us where the shunting can occur and the failure of the development of the mitral valve, and where we are having a common atrioventricular valve. And you can see that your left ventricle and your right ventricle, they are sort of underdeveloped, and you can see the enlargement of your right atrium, and that there is the shunting of the blood, which can be explained the pathophysiology later with the diagnostic test as well. And then we're saying the pathophys, the majority of the complete AVSD, the atrioventricular valve orifice is equally committed to the right ventricle as it is to the left ventricle, like we have already seen on this picture here. So it is supplying sort of equal amount of blood to both the left and the right ventricle. And then while in some patients, the orifice can primarily be committed to one ventricle, either the left or the right, and this is going to result in the hypoplasia of the other ventricle. And then the patients with complete atrioventricular septal defect have only one large heart. That is, as we can say, the mitral valve and the tricuspid valve has somehow failed to develop, giving you one large heart. And complications that are associated with atrioventricular septal defect, it's an inlet and or interarterial and or interventricular shunt, like I have showed you on this picture. And the valve regurgitation either from left to right, resulting in the shunting of the blood. And this is going to lead to your congestive heart failure with or without pulmonary hypertension. And then this may usually present in early infancy or immediately post-birth. Or it can be seen post 6 weeks when the child has already been discharged from the hospital. And here, we are just looking at the partial one, which is just either, the partial one can exist between the ventricles or between the atria. Here you're looking at the atrial septal defect. And then here, we are looking at partial atrial septal defect that is presenting at the ventricles. And that's me. Thank you.
Okay, good afternoon or good morning that side, everyone. My name is Sinan Grovu, and I'll be presenting the health history and the physical assessment of the AVSD presentation. So with the basics of history taking, so you firstly going to introduce yourself to the primary health caregiver, and the child, if depending on the age of the child. And then that is how you obtain consent, and you also explain to them what you're going to do and the reason for obtaining the history and doing the assessment. For the purpose of this examination, we have acknowledged that AVSDs can be discovered from intrauterine stage infancy to late in life. So we'll concentrate on a child who is about 8 weeks old. So on obtaining biographical data, obviously we'll ask the primary care provider the baby's name, baby's date of birth, and gestation to see if the child was born prem or postnatal, and also determine the corrected age, and then also demographical data of where the family stays to check like the socioeconomic status of the family. And then labor and delivery. Okay, so this is where we're gonna get to the past medical history, the maternal history. So with labor and delivery, we're gonna ask the duration of labor, was the labor prolonged? And then uterine activity, and how was the baby during the first hour of life. So with all of this, we're gonna check that maybe if there was poor intrauterine activity from lack of movements of the fetus in labor would have been prolonged, as there was maybe insufficient pressure on the cervix for baby to come out. And then baby might have been born floppy. And then also the floppiness could have been if maybe there were drugs given before, during delivery. Also to ask if obviously if mom got opioids, the baby would be born floppy and then having low APGAS. And then should the poor prognosis persist for over an hour, which is the golden hour of life, maybe the child will be diagnosed. Then we can maybe see if maybe there was opioids that were reversed. They reversed by giving naloxone. And then if all of that was done, then we can consider testing for congenital heart defects. And then also infections, they say viral infections that were contracted during the first trimester can cause AVSD, such as rubella, chronic medication that the mom was on, like infotins and warfarin, excessive alcohol intake, which may cause fetal alcohol syndrome, is associated with AVSDs, amongst other CHDs. And then if the mom had diabetes, we should ask if mom maybe had diabetes prior to falling pregnant, as it said that there's 4%, 4 times chance of giving birth to a baby with AVSD if she had a diabetes prior, also in gestation. And then the obstetrics history, we should find out if mom had previous miscarriages or stillborns or sudden infant death. Also, if maybe there was an adult who passed away, like unknowingly, this could be from undiagnosed CHDs. And then the baby's postnatal and present history, their medical history. So we'll ask if the mom, if there's any concerns or what medication baby has been on, and then how baby is, their level of response and activity, if the child appears lethargic, respiratory problems, like if she'll report that the child had breathing, the abnormal breathing patterns, and maybe frequent visits to the local GP or clinic, which could be indicative of recurrent lower respiratory tract infections. And then also what other medication the child was on that maybe they got over the counter, or herbal medication that the child was on. Developmental history, will ask the mom like the growth, how child has been. So poor weight gain and delayed development is evident with babies with AVSDs, and then their milestones will be delayed. So example, for like an 8-week-old, like holding their head up and laying on their tummy, falling objects with eyes will be delayed. And then the nutritional history will ask the mom the infant's feeding habits, e.g. if they tire out easily when breastfeeding or feeding, if maybe with that feeding the baby sweats and becomes lethargic, so can't complete a complete feed at a given time. This is due to high demands of oxygen with activity. So family history, it is said that there's a 14% chance of recurrence if the mom had AVSD versus only 1% recurrence if the dad had AVSD. And then with siblings, it's said that if the older children had AVSD, there's a 2% recurrence. So we will also find out if genetic counseling was done for the following pregnancies. Physical assessment, we're still gonna continue to obtain consent and wash our hands and don PPE as needed. So here we're gonna tie information received from the mom with our findings. So on inspection, we observe the child in their environment where the child is, so the waiting room, the hospital bed, and take note of their appearance and behavior, so their activity, alertness. Note if the child appears alert and engaged or quiet or listless. Cyanosis will note a bluish discoloration of the skin or inadequate oxygenation of the blood, which could be from the shunting, shortness of breath and tachypnea because of the lungs being overloaded. Edema, it typically presents with the swelling of the limbs and eyelids from the CHF. The weight, we'll note if the child appears healthy for their age and height, and then we'll also note syndromic features. So such as we'll look at the stature and facial features. So like a flattened face and bridge of nose or almond-shaped downward eyes, which suggests Down syndrome, which is more prominent with babies with, it's found with babies with AVSD. And then temperature, we go now to palpation, sorry. So with palpation, we're gonna check the temperature of the baby. So when we touch the baby, in healthy babies, their hands and feet should be symmetrically warm, suggesting adequate perfusion. So with babies with AVSDs, we find that the hands and feet are cool or clammy, which suggests poor peripheral perfusion. And then also we'll check edema, so you palpate. So due to the heart failure, the baby will show edema on the extremities. We'll also check the capillary refill time. So with babies with AVSD, it will be greater than 3 seconds due to the poor peripheral perfusion of the extremities. The pulse, an irregular pulse is common with AVSDs due to arrhythmias. The rate will also be fast, so the child will be tachycardic. With the chest, we'll assess the quality of the chest activity. We'll also note hyperactive precordium due to tachycardia and hypertrophy of the ventricles, resulting in volume overload. And then we'll also determine the point of maximal impulse to establish whether it's a right or left ventricle dominance. So they say with normal newborns and infants, they have right ventricular dominance and they present with greater right ventricular impulse than older children. If the impulse is more diffuse and slow rising, it's called a heave, which will be present in AVSD, and a thrill is felt with light palpation from the chest wall. And then the auscultation findings, there'll be, in the complete AVSD, there'll be the active pericardium due to the volume and pressure overload of the right ventricle. There'll be a single loud second heart sound as due to the pulmonary hypertension. There'll be a grade 2 to 3, 6 systolic murmur. Sometimes a diastolic murmur at the apex and low left sternal border will be found. And then in an incomplete or partial AVSD, there'll be a wide splitting S2 and a mid-systolic S2. A mid-diastolic rumble may be present at lower left sternal border, blowing apical murmur of mitral regurgitation. And then when you auscultate the lungs, you will hear caused by basal crackles, which may be a sign of pulmonary congestion secondary to the CHF. Okay, so we were supposed to play a sound of the AVSD, but we're having problems with our network.
Good morning, everyone. I'm Tshireletso, and I'll be presenting the diagnostics and medical and surgical management. So for AVSD, it can be diagnosed prenatally and postnatally. Prenatally, antenatal ultrasound would be done during a anomaly screening, and on the obstetric four-chamber view, a common AV valve would be seen. Postnatally, there are various diagnostic procedures which can be done, such as chest X-ray, ECG, echocardiography, MRI, and cardiac catheterization. On chest X-ray, a patient would be found to have cardiomegaly and increased pulmonary vascular markings as seen on the picture depicted below. They could also be found to have enlarged right atrium and a prominent pulmonary artery. On the ECG, they'll present with an abnormal ECG with prolonged PR intervals, partial right bundle bunch block, and superior P wave axis. The echo allows for the visualization of the ASD and the VSD. With the spectral and color flow Doppler, it will show a left to right shunt, which would also aid in identifying the magnitude of the shunt. With patients with complete AVSD, a common AV valve with 5 leaflets will be appreciated. And in a PAVSD, there would be an abnormal mitral valve. A gooseneck deformity would be appreciated on the subcostal imaging, which occurs as a result of the elongation and narrowing of the left ventricular outlet, as shown here on this diagram. So there's the left ventricle, and then there's the gooseneck effect. On MRI, it would assist in identifying ventricular hyperplasia and also predict the size of the ventricular component of the defect. It also aids in measuring the regurgitant fraction in the valve regurgitation. The main objective with cardiac catheterization is to determine the extent of the defect and the amount of blood which is flowing through the heart. It's an important diagnostic procedure which needs to be done prior to surgical intervention, as it would measure the pulmonary vascular resistance. So with infants with AVSD, they're found to have increased oxygen saturations in the right side of the heart due to the shunting of blood from the left side to the right. And they also present with elevated pulmonary artery pressures and pulmonary vascular resistance. So in instances where the patient has elevated pulmonary vascular resistance, it can be treated medically, either with oxygen, inhaled nitric oxide, and other potent pulmonary vasodilators. For the medical and surgical management of patients with CAVSD, they would present with signs of heart failure by the age of 6 weeks. So the goal of medical management is to optimize their condition prior to the corrective surgery by improving their cardiac function. So the child would be put on diuretics in order to aid with reducing the pulmonary congestion and fluid overload. So they could use either loop or thiazides, Furosemide is the most commonly one used. ACE inhibitors also used to reduce the afterload, which in turn will assist in decreasing the left to right shunt and the possible mitral regurgitation, which can occur. Inotropic agents such as digoxin are used to improve the myocardial contractility, and the infant would be given NG tube feeds and caloric supplementation in order to promote adequate nutrition, especially if they have failure to thrive. The surgical management for CAVSD is the primary complete closure is the preferred method where the atrial and ventricular defects are closed and two separate component AV valves are formed. So it's usually performed in early infancy to avoid pulmonary vascular disease. There are three techniques which are used: the single patch, the two patch, and the modified single patch. The single patch repair, they use a prosthetic patch and close the ventricular and atrial communications. And then the common AV valve is then divided and reattached to the patch, as you can see in the picture below here. And then the two patch repair, they also use a prosthetic patch material to close a ventricular septal defect. And then the common valve is then attached to the top of the patch. And then for the atrial component, they will use the pericardial patch, which is then also sutured to the common AV valve and the ventricular patch, as also shown below here. And then with the modified single patch repair, the common AV valve is directly sutured to the crest of the ventricular septum. And then pericardium is used to close the atrial component. And then it's sutured to the crest of the ventricular septum as well, as you can see here. So then at the end of the surgical procedure, there will be two valves. Well, there'll be valves on each side of the heart, on the right and the left side of the heart. And then with the partial AVSD, it's an elective surgery which is performed between the ages of 18 months and 3 years. The repair involves closure of the ostium primum defect and the mitral valve and a mitral valve valvuloplasty, which is done in order to reduce or eradicate the mitral valve regurgitation.
We are now going to be looking at the future issues or the outcome or needs for this child or the patient with the atrioventricular septal defect. We might see premature death due to complications of congestive heart failure and or pulmonary artery hypertension. There might be prolonged length of stay in the hospital, particularly in the ICU. Atrioventricular valve regurgitation, like we have already described in this procedure that we have discussed earlier on. And there will also be a scar down the middle of the chest of the child, which is going to be associated with the social involvement or interacting with other children, which might also lead to lowered self-esteem, which might also say that the parents will have to be encouraged to take this child for counseling. Then there will be also an artificial valve that may need to be replaced, because as we know that these valves, they are artificial, they don't grow as the child grows, so the regurgitation might recur, resulting in that the child might have to be taken back to the hospital. And then a failure to replace the valve to work effectively may also require that the child might have to be taken in and out of the hospital, which is also might have an impact on the parents. And then there also might be prolonged use of anticoagulants so that we can, the valves or the patch that has been placed in shouldn't clog with the blood, and they can have a number of implications for this a patient's health and lifestyle. So some patients may also develop subaortic stenosis, which is a blockage below the aortic valve, and then they may need to an open heart surgery. And then on the other hand, some of these patients may not have serious problems. They might grow normally with effective support from the healthcare givers until they are at about their teenagers or they enter adulthood. And these are our references. Thank you. This is our chart that shows an open heart surgery. And as you can see, it is a complex and it can be a trauma to the parents. Thank you.
Excuse me. Thank you very much for that very clear and thorough presentation on complete and incomplete ABSD. In particular, there was so many strengths with that presentation, but a couple of things that stood out for us were you really, throughout the entire presentation, really kind of went back to differentiating the difference between complete and incomplete ABSD, which is often a real point of confusion for people. So thank you for doing that. Such a nice job with that. And you even went as far as getting into some of the unbalanced ABSD, which is also very meaningful. Your diagrams were excellent. We also really liked how you pulled in principles that have been taught earlier in the course, such as heart sounds, the principles of health history, particularly family history of congenital heart defects and reoccurrence, but then you took it a step further to within the context of ABSD, so the recurrence within with family history with ABSD, as well as you reinforced the impact of maternal health on potential congenital heart defects. So again, thank you very much for that presentation.
Thank you.
Thank you.
So we're right on time for our next presentation.